everyone. Assalamu alaikum and good morning. Welcome everyone to today's session. Lovely Wednesday morning today. My name is Fariz Yahya. I'm a consultant rheumatologist from the Department of Medicine, and I'll be moderating the first session for today. So when we talk about rheumatology, the terms biologics and DMARDs will all come very familiar and associated with rheumatology. And for this morning, we have our speaker, Professor Sargunan Sockalingam, who will give a talk. It's going to be about 30 minutes. So the title of his talk is From Willow Bark to State-of-the-Art Targeted Therapy, Evolution of Rheumatological and Musculoskeletal Diseases, Treatment, and the Future. So Professor Sargunan was the former head of unit for rheumatology. He has a special interest in autoimmune diseases and also SLE. So Professor Sargunan, when you're ready, the stage is yours.
How are you?
Good morning. Looking forward to hear your talk, and I'm sure everyone here is also eager as well.
Yeah, glad to be here. Glad to be here. Thanks, Fariz. Thank you. And I'd like to thank the Faculty of Medicine organizers of the wonderful breakfast meetings. We all enjoy these meetings. There's such a varied topics, and I must say, as someone who's an ardent follower, I learn a lot from these meetings, and it truly is a great honor to be given the stage here today, and I hope I can do justice. I do have to say a bit of warning that keeps aside. I'm here in I'm here in the office, and it says internet connection unstable. Oh dear. Well, we're going to manage what if something goes off, it's just too bad. I'm going to go on to my hotspot and I'm going to open up my laptop. That may take a delay, but let's hope everything goes well. Yeah. Now I'm going to share my slides. Let's hope we can see this. Right. There we go. Okay, so welcome everyone, and I'm very excited to give this talk to you. It's a little bit of a combination of history and mind-boggling pathways in autoimmune disorders. So it's going to be, I'll try to make it as interesting as possible, but I understand that I am actually giving a lecture to some of the most talented, some of the most really wonderful scientists, physicians, and doctors in various departments in the Faculty of Medicine. So I will be mindful in that. And if there's any mistake or anything like that, I'm very free to be opened and corrected left, right, and center. And some of the things that I talk about have actually been covered in previous breakfast meetings. And I do hope that my one wish is that someday we could all do this once again physically live, and perhaps we can move out the online platform. But I do understand that that's quite a difficult ask in this day and age. Right. So I'm going to talk to you about willow bark. So this is not a botany lesson, but it may have something to do with lots and lots of plants. And then moving on to state-of-the-art targeted therapy, where, the only thing I'm not mentioning is actually about robotics in the treatment of what we call as RMD. Now, RMD is a broad term, which is rheumatological and musculoskeletal disease. Now, we always think of rheumatologists when we go and meet when we go out and meet people. Oh, you're a rheumatologist. So what exactly is? Everybody knows what's a cardiologist and what a nephrologist and neurologist. But rheumatologist, what do you do? Do you spread rumors? Are you a specialist in rumors? Lame joke for a Wednesday morning, but yeah, so it's quite an interesting field, but essentially we're talking about musculoskeletal diseases. And musculoskeletal disease can happen anywhere from de novo autoimmune process to something as degenerative that unfortunately many of us will already be experiencing as we all get older with age. But bear in mind, by and large, our patients are generally very young. And how is this working in the future? Now, just a word, usually October is what we celebrate as the awareness for arthritic diseases. And usually the second Saturday of the month is designated as World Arthritis Day. And we do have events. We ourselves a few years ago had a fun run right here in which was very successful. We raised about close to about, I think, 70 to 75,000 ringgit. I'll tell you a little bit about the fund that we actually do manage. And let's now go into the deep dive in the talk. Now, the gentleman that we see on the right of your screen is Hippocrates, that we all know very well. And very frequently, the treatment using willow bark was actually attributed to him. But that's not really true. He used the leaves, the willow leaves, for treatment of postpartum problems such as postpartum pain, recovery, the uterus getting back to its normal size. The fumes would apparently help. He didn't talk much about arthritis. The person who actually started the use of a willow is actually one Reverend Edward Stone in Oxford. Now, what he did was, because he's a person who suffered from fever, body aches, and at that time they had access to Peruvian bark. Now, you'll see a little bit of Peruvian bark, but that didn't work. And he found out that from history, that willow bark, and we see willow trees everywhere. There are some here in as well, beautiful trees. He would take the bark, and what he did was he took quite a lot of them, put them in the oven, dried them, and then made them to powder, and started taking the powder, and lo and behold, his fever and body ache had gone. So this is sort of the beginnings of one of the first treatments that we did for rheumatological diseases. And so what happened, that's the willow tree and that's the bark. And this happened in 1757. Now, after that discovery, that initiated a whole lot of research done mostly in Switzerland and at the time, and also in Germany at the time. There were many pharmacists, chemists, and so on. They were experimenting, and final result is in the late 1800s. We developed what we call the bottle that you see now, one of the first bottles of aspirin that was developed by Bayer. I'm sure there are many people from the pharmacology department. I hope I'm not crossing your line. That absolutely the knowledge is all yours. But of course, the aspirin, what's interesting is that what is this is salicin. So the salicin, that's the component. But now, remember that 1876 onwards, it was first used by Dr. Thomas McLagan in Scotland to treat rheumatoid arthritis. So, and they found that it actually worked very well. Now, what we know as acetyl salicylic acid, ASA, which you see the cardiologists love to write ASA every time. So that's acetyl salicylic acid. That actually doesn't come from the willow, but actually it started from the meadowsweet plant. Now, all these plants are all found everywhere in the Europe and so on. So I guess now everything is synthetic. And this is the drug that we have till today that we are using. Now, on the subject of botany, the plant that you see here is the autumn crocus. And the gentleman, the beautiful artistic image that you see is one physician by the name of Alexander of Tralles during the Byzantine era in the 5th century after Common Era. Now, exactly what this is important is, I think you will know that this is where we get the alkaloid cinchona. The alkaloid colchicine. Sorry, cinchona is different. The alkali colchicine, and colchicine is the treatment that we are using today for the treatment of gout, known as the diseases of kings. It has been described for the last 5,000 years back in the Egyptian days. They knew that it is a disease of affluent people, but we see that till today, and colchicine is a drug that we are using very much till today, very effective within the first 24 to 48 hours of the acute onset of gouty arthritis. I talked a little bit about Peruvian bark in my slip earlier, cinchona. This is it. We are talking about quinine. Now, why am I talking about malaria? Well, let me tell you, much of the drugs that we use in rheumatology, we actually pinjam from other specialties, other disciplines. And this is no different in Peruvian bark, which we extract quinine from. And from then, there was a treatment for malaria. Unfortunately, quinine is horrifically bitter. It is so bitter that the British officers who were all stationed here, they put this quinine into tonic. And this tonic water, which was also still bitter, what they did was they added gin. So they had that drink called gin and tonic, which is very popular today. And that's the excuse for them. So you drink this beverage and you're cured of or you don't get malaria. Well, look, we can't think of giving quinine for our patients, but it is the start from which they derived the similar structures of quinine. We got chloroquine, and finally from chloroquine, this structure you see here is hydroxychloroquine, a drug that we are using for the treatment of lupus and also as a disease-modifying agent in rheumatoid arthritis. Now, how could I not talk about glucocorticoids, steroids? Steroids is a drug that we use and give us a very close working relationship with the endocrinologists. We do refer quite a number of cases to them well, guilty as charged, but the power of the glucocorticoids. So you will see in this image in 1930s is representing how physicians and scientists and chemists were trying to extract adrenal extracts, basically adrenal gland extracts for the treatment of people with hypocortisolism. And what they did was they were able to isolate the structure. And from the 1940s, as it happens, the image right smack in the middle, this tall gentleman here is Dr. Philip Hench from the Mayo Clinic, demonstrating how a patient was unable to extend her knee now from rheumatoid arthritis after starting treatment with cortisone. Lo and behold, a miracle treatment had appeared. And from then on, we developed a cortisone, prednisolone, and that was an explosion of therapeutic agents. Now, this explosion of therapeutic agents was regarded as what we call the miracle treatment, and everybody said, look, we've found this treatment for arthritis. So much so in 1948 or 49, Dr. Philip Hench and his colleagues won the Nobel Prize for Medicine for their development of glucocorticoid therapy, which we are using till today in various fields in medicine. But it wasn't long until 1950s and 1960s, as you can see in this image here, every single side effect and adverse effect of glucocorticoids reared its head, and we have osteoporosis, diabetes, susceptibility to infection, thin skins, the Cushingoid appearance, and so on. That became very, very prominent. So very soon, there was a search for another agent that could help in rheumatological disease. Now, I'm somewhere in the 1950s to 1970s, but allow me to take you to the 1930s. Now, this very sad image is an image of the trench war soldiers. And what happened? These are the people who survived the attack with nitrogen mustard gas. Nitrogen mustard gas, that is a war time weapon that is used, is very scary. It can be manufactured easily. There are apparently rumors that they are still being used till today. Now, nitrogen mustard gas can be incredibly toxic, but these are the soldiers who survived. And when they survived and when they went home and they had all the illness, the doctors noticed one thing: their white cell counts are sometimes undetectable. Their white cell counts are very low. Now, it is around this time that treatment for cancer had come about. And I mentioned a rheumatological disease. We use a lot of drugs, and we really owe a lot of our drugs to oncologists. Now, what happened was the pro-drug for nitrogen mustard is cyclophosphamide. And they realized that a drug like this, which can be toxic to cells, and we know that tumor cells absorb these drugs much faster. Therefore, chemotherapy was born using nitrogen mustard, or rather pro-drugs of nitrogen mustard. You have examples like cyclophosphamide, chlorambucil, melphalan. These are drugs that all had developed, and they were using this for the treatment of cancers. Now, but of course, let's be clear, nitrogen mustard and cyclophosphamide are being used for the treatment of lupus till today, and in fact, in some vasculitis disease. Now, I take you to the 1940s and 50s. The gentleman on your left is Dr. Sidney Farber, who then started experimenting with the use of antifolate drugs. Now, why antifolate? You know the folic acid is very important in the metabolism of your DNA. Without folic acid, there's no DNA. The DNA breaks up. And they realized by actually blocking folate that you can actually help bring down tumor cells. And that was Dr. Sidney Farber doing this. This beautiful building is, in fact, Harvard Medical School. And that actually did some work. It was being used in leukemia quite fairly successfully, using it till today. And then bearing in mind that we work very closely with oncologists, Dr. Michael E. Weinblatt, also this must be something in Boston where the water is really good. Everybody is doing fantastic research and getting out all these therapies and doing really very well. Dr. Michael Weinblatt and his team, I think we owe a little bit of our salary to this gentleman because we are using methotrexate left, right, and center in many rheumatological diseases. This is in Boston, the Brigham and Women's Children's Hospital. And here we go, the paper that came out in 1985 using low-dose methotrexate in rheumatoid arthritis, the drug that we are using till today fairly successfully, right? Now, I take you to the 1990s now. It wasn't until about 20 to 30 years later, these gentlemen, again from the UK Imperial College in London, the gentleman on your left is Sir Mark Feldman, the gentleman on right is Sir Ravindranath Maini. These gentlemen, these immunologists are credited with the development of the anti-TNF drugs, one of the first monoclonal antibodies to be prepared, to be used in the treatment of rheumatoid arthritis. Again, as revolutionary as the use of glucocorticoids in the late 1940s, this was a game changer for the treatment of rheumatological diseases. Now, I take you a little bit for a little bit of immunology. I'll try not to confuse you. Now, just look at this image here is the lymph node. Now, we know the lymph node, there are many, many cells. There are T cells, there are B cells, there are dendritic cells. What's important are the antigen-presenting cells. And you have here the synovium. The synovium is regarded as the powerhouse of the human body. Every single imaginable cell is in the synovium. The synovium that you see in the joints, and it reacts. That is why when we all have diseases like dengue and chikungunya and COVID, our joints ache because one of the first places to react will be the synovium. And there is a communication going on. At the risk of being too complicated, I just want to say that we all should know about antigen-presenting cells, which is the dendritic cell, and that has a relationship with the T cells, your helper T cells that then differentiate into whether it's Th2 or Th17. In rheumatoid arthritis, it tends to be Th17. And as you see here, and there's a communication of the B cell, and these B cells are the ones that are secreting the plasma cells. The plasma cells are the ones that's producing the anticyclic citrullinated peptide and the rheumatoid factors. And this co-play between T cell and antibodies are now integrating to create the perfect recipe for an immune response, inflammatory response. And here you'll find various cytokines. To confuse you even further, the interplay between dendritic cell, macrophages, T cells of the various types, and B cells, and there are different chemicals. It's like if I have a friend, I speak to my friend in perhaps English, and another speaking to another friend in Mandarin. That's pretty much a kind of language that's going on, if you like. And so interleukin-6, we know, is one of the primary drivers of the antigen-presenting cell towards the macrophages and towards all the other cells that will initiate the inflammatory response that have certain targets towards the so-called self-antigen where we lose our tolerance. So the macrophage is even a bigger play. So you can see that TNF, interleukin-1 and interleukin-6 are big players. What does it say? That means if you block these pathways, you will achieve a situation where you're not triggering the osteoclasts, you're not triggering the chondrocytes. Guess what? It works very well. And one of the biggest drugs, one of the most important drugs that we are using with the plasma, that rituximab. Rituximab is a drug that we are using for many situations. You use it for lymphoma, you use it for rheumatoid arthritis, you're using it for lupus, we're using for autoimmune hemolytic anemia, so we're using for vasculitis, pretty much everything under the sun, because we do know that the importance of the B cell pathway. And this is, again, another, what I'm trying to show you is that we have agents to block every single cytokine. Okay, not every single cytokine, many cytokines. I got ahead of myself, but we are getting there. We are getting there. So we have all of these drugs that we are now using in various diseases. So not just in rheumatology, I think you're using it in infectious diseases, you're using it in gastrointestinal medicine. So that's why we rheumatology, and I'm not trying to boast you, but rheumatology was one of the first to start using in all these diseases, in rheumatoid arthritis, in ankylosing spondylitis, and so on. And once we knew that drugs such as adalimumab, golimumab, and so on, and ustekinumab were being used, have implications in other other specialties, they approached us for help, and we are happy to see that everyone's very comfortable in prescribing these drugs. Now, the other one is now what I was talking about was actually talking about the extracellular environment. We have drugs that target the intracellular. To be fair, glucocorticoids actually go into the nucleus. And here we have our understanding of the JAK-STAT pathway, the tyrosine kinases, and this is where the IMIP drugs comes in. My first experience of such drugs is actually in hematology with the development of what drug we know as imatinib, Glyvac, that is used in the treatment of chronic myeloid leukemias. And chronic myeloid leukemia patients are doing very well on this drug. Survival rates have increased, and it's absolutely amazing to see how by blocking the JAK-STAT and the tyrosine kinase pathway, we are actually going into the nuclear level and affecting cell proliferation. We are also affecting the ability of these cells to actually create inflammatory cytokines that trigger rheumatoid arthritis and all the other diseases, and also to suppress the inflammation. You could do that with the JAK-STAT pathway, to suppress inflammation and to actually stop the formation of these pro-inflammatory cytokines. So the disease-modifying anti-rheumatic drugs, when we used to have only conventional synthetic, now we have the biologics of various monoclonal antibodies that target various cytokines, and the target synthetic drugs, that is the tofacitinib, baricitinib, upadacitinib. The list is growing. The list is absolutely growing. So where are we in all of this? So I'll get a little bit to that. So where are we today? Today, we know that biologics have really changed the lives of patients with RA. I want to say conventional synthetic. Yes, they have. But bear in mind, there are at least 40% of patients who do not respond to conventional synthetic drugs. But let's be clear. Our first line will always be conventional synthetic drugs. Methotrexate is really very cheap. Prednisolone, absolutely very cheap as well. Hydroxychloroquine is also a very cheap drug. Sulfasalazine, very cheap drugs as well. Of course, once we cross the drug to leflunomide and so on, they start becoming a bit more expensive. But let's be very clear that we are still very much in favor of conventional synthetic. However, biologics have changed the environment. We are doing very well with biologics. Bear in mind, there is some failure, but we have options when different patients respond to different drugs. And now the holy grail in rheumatology is to find which patient responds to what drug. So we don't have to waste time going through the entire line. Maybe this patient will respond to rituximab. Maybe this patient will do very well with tocilizumab. Maybe this patient will go away straight and start with tofacitinib. Right. So these are the things that we're actually working on. There are some signals that tell us, and we are encouraging treatment with biologics when there is financial capability. I wish I could not have to talk about cost. Unfortunately, economics is a very, very big in healthcare today. The amount of discussion that we are having on healthcare, it's always about economics. It's all about making profits. So there's something here that we actually need to address. And we're very happy to work with our colleagues in the Department of Pharmacology, our social preventive medicine, to learn more about health economics in this field. So the cost saving from the prevention of deformity, disability, and morbidity, it's not easy to look after sick patients. It costs money. And good news is there are biosimilars. The patents are all over. So biosimilars are coming up. So these are very, what you call accessible drugs. They are much cheaper. Now, I'll just go through a little bit. I know I'm running out of time, but there's now targeted therapy using dendritic cell, what we know as tolerogenic cells. What we do is we take the dendritic cells out of the body. We train the dendritic cells to actually recognize the self-antigens and not to attack them, and to reduce the inflammatory response. So this has actually been working. So it's a form of vaccination. They tried oral therapy, they tried injectable therapies. So there are some papers on this. Unfortunately, the sustainability of this treatment is not really doing very well. They're working towards that. The other thing that we talked about is, and I know I'm so honored that we've had actually 2 talks on nanoparticles from our colleagues here at the mind-blowing talks, actually, in terms of how you use nanoparticles. And we combine drugs, NSAIDs. And I didn't talk much about NSAIDs, but we use NSAIDs and COX-2 inhibitors. And what we can do is using nanoparticle delivery techniques, going straight into the cells and to reduce the inflammatory response. Now, studies are going on, and they are giving other drugs as well. They're putting in tocilizumab, they're putting in gold-based nanoparticles. They're also combining anti-TNFs in nanoparticles. You need smaller doses. We are talking about less NSAIDs side effects by using nanoparticle delivery. I think CAR T cell is a topic that's very exciting for us. It's a lecture entirely on its own. It's our ambition to be able to work with our hematology colleagues to actually do CAR T cell therapy for diseases like lupus and scleroderma and rheumatoid arthritis. There has been some reports of success, and also targeted therapy using GM-CSF, colony stimulating factors, for the treatment of rheumatoid arthritis. These drugs are coming up as well. There's also mesenchymal. Everybody talks about stem cells. Yes, stem cells are there. We are very cautious about this. There's research going on, but targeted delivery is very important. This is probably something we work with nanoparticles. Just to talk about the excitement that started from the year 2007 all the way down to 2022, looking at the technology. Watch this space. Nanoparticles is going to come in, and I think this is something that here we in Faculty of Medicine, University of Malaya, could actually think about working on nanoparticle technology. I believe we have the expertise. We have fantastic people working here. Hopefully we can get grants and actually start our own research platforms on this. Just to talk to you a little bit about the cost effectiveness. Much has been talked about in the use of advanced therapy to reduce the overall cost, the economic benefits. Now, you really do not want our patient to keep coming back to the hospital, get hospitalized, get treated with drugs that don't really, I mean, they do work, but not as effective. There is definitely economic data to show that it really works to treat our rheumatoid arthritis patients and musculoskeletal disease patients early to perform, to avoid deformities and disabilities. And no, treatment is evolving rapidly. There's an urgent need to translate this to efficient healthcare delivery. Cost is a factor, but some good news. I think if you're following the budget, you would have heard, because of the work of the people from Arthritis Foundation Malaysia and Psoriasis Arthritis of Malaysia, well, they actually sent a memorandum. They spoke before the budget to ask for 20 million ringgit for the treatment of autoimmune arthritis. Well, congratulations. They got 25 million for the treatment of autoimmune arthritis, such as rheumatoid arthritis and psoriatic arthritis. Now, how is that going to translate? How are we going to have access to it that we can use for our patients? I'll leave that to your imagination. The other thing is the research possibilities that are immense amount of research that I hope in the future our rheumatology unit can work with the other units here. And so this is the picture of the second floor Menara Timur Infusion Center. We have our patients coming in and getting our infusions here usually every Monday. We are very proud of our our cooperation with our nursing staff, who've done some fantastic job making this a very easy process for us. With this, I'd like to thank you. I do believe I've kind of about 2 minutes. Perhaps we have questions later. I'm very happy to take them. Thank you very much. And over to Professor Dr. Moy for her next talk. Thank you very much. Bye.
Thank you very much, Professor Sargunan. It's a very interesting and fascinating lecture. We do have a couple of minutes just for Q&A before we go on to the next session. I do have a question for you, Professor Sargunan, from the chat. So one question is, are the spectrum of connective tissue diseases increasing in terms of incidence? Is it related to more pollution of the air, or is it the food environment? If so, looks like we're playing catching up on the game of destruction of our body. So any comments on that in terms of environmental influence to diseases as well?
Thank you for the question. So in just before the pandemic, we actually did a census of the number of cases that we have. Rheumatoid arthritis is by far the largest number. We have about 750 patients at that time. I can tell you, I wish we actually did a follow-up. Definitely the number has increased. We have about 650 patients on lupus, excluding lupus nephritis. Our nephrology colleagues have a huge data bank of patients. I can tell you now, our numbers are increasing post-pandemic. As to what is the cause? I think number one, it is the awareness. We are now more aware of autoimmune diseases such as lupus and rheumatoid arthritis and ankylosing much faster. We are picking them up much faster. There's there's a lot of awareness. As to the anecdotal, whether this is something to do with the environment, I cannot say no. I think there are many, many factors. Now, environment is important. Now, ultraviolet rays, ultraviolet radiation, we get UVA and UVB. These are increasing in Malaysia. They are increasing in the world because we know that the penetration through the ozone layers are becoming very powerful. Is it in our water? It's very hard to say. We know that drug-induced lupus is a very common thing, and with all the genetically modified organisms and foods and vegetables that we're getting, that is a possibility. And with the greatest respect for everyone, I've been vaccinated for COVID. I've got my 3 vaccines of COVID. There are some rumors saying that the vaccination with probably the RNA molecules may have a triggering factor. So this is something that needs a lot of research. We need controlled trials to observe this. And that is something, Prof. Chan, that we really need to look into. I will not say no, but we need data. We need data. And right now it's absolutely anecdotal. But it's better to be cautious and say, yes, something is in the air and the water. Thank you.
Thank you very much. And I think in the interest of time, we have to move on to the next lecture, but we truly appreciate, I really enjoyed your lecture, Professor Sargunan. I hope everyone here enjoyed the lecture too. So I will pass it on to Professor Victor Ho as the moderator for the next lecture.
Thank you, Prof.